Okay, I'm Paul Ginsberg, and I'll start this panel on provider payment reform in the traditional Medicare program. A lot that's come before is clearly relevant to our panel, and the interest in reforming provider payments in traditional Medicare has been very broad, very real enthusiasm by policymakers, and we've seen that in the recent SGR fix and the statements by Secretary Burwell about her goals for the proportion of Medicare spending that's in these reform programs, and also a lot of interest in the leaders of providers and the insurance communities. I think this does have potential to play a very important role in traditional Medicare to reduce outlays and to improve outcomes for the beneficiaries. The issue is, will this potential be realized? And I would say that whether we realize this potential is very dependent on making the right changes in Medicare, because I don't think that we're headed there right now. And this paper is about charting a course to get there. Now, some have commented that these approaches are really just a transition to Medicare Advantage. And certainly some individual delivery systems might have such a perspective. They might see it as an opportunity to prepare themselves to then, go further and get into Medicare Advantage as insurers. But we see the ultimate share of Medicare Advantage being dependent on beneficiaries and their decisions as they weigh the cost and quality of the alternatives, hopefully with as level a playing field as possible. And actually, if payment reform in the traditional program succeeds, it could even slow the shift to Medicare Advantage, as then the traditional program is a more attractive, more efficient program than it is today. Now, the experience to date is that we've had a wide variety of approaches being piloted, and I think that's very positive. In most cases, we don't have results yet, or many of them have shown small savings. I think the results so far have been encouraging enough to move forward, revise the models, but I don't think it's impaired anyone's conviction that there really is potential in this approach. I think the key variable now and in the future is provider take-up. This won't succeed without wide provider participation, and sometimes the emphasis on short-term savings for CMS has undermined the attractiveness to providers. I think some of the issues that are most serious are the issues of getting the benchmarks straight. Now, what I mean by a benchmark is what the provider spending is going to be to compare to determine whether there are savings or losses for the provider. And the voluntary nature of the pilots to date has really forced the program to use benchmarks that are based on each individual provider's experience spending-wise in the Medicare program. And this means that you can only reward improved performance. You can't reward providers for very good performance if they've all long had very good performance. So it discourages provider participation in two ways. First, if their spending is already low, they have less potential to do well and garner savings to share. And if benchmarks either will be or might be rebased in the future, this significantly undermines the business case for providers investing to improve their delivery. And this is a real problem in particular for the Bundled Payment for Care initiative that the Innovation Center is pursuing, which rebases the benchmarks very frequently so that plans can have providers can have an initial significant reward, but then getting a further reward in the future is very difficult. Now, there are two solutions to this benchmark issue. One is to avoid rebasing provider-specific benchmarks until the whole system is ready to transition to community benchmarks. And the other, I think more important, is to bring elements of compulsion into the process. Some reform payment approaches can be mandated. Those where pilots have shown good results and are manageable for most providers. So an example would be bundled payment for joint replacements. That could be made mandatory. And once you mandate payment, you can include a transition from provider-specific benchmarks to national or regional benchmarks. Also, you could peg the rates to generate federal savings based on what providers are expected to be able to achieve. And there also are softer approaches, as we see in the alternative payment mechanism provisions of MACRA, the SGR fix. And this could allow where physicians are offered higher rates if enough of their practice is in alternative payment mechanisms. And this could allow the blending in of national or regional benchmarks if many providers respond to those incentives and are participating in such mechanisms. Paper has some discussion about how to choose whether to use a national or regional benchmark. And the answer is that for population approaches, it should be regional and it should align with Medicare Advantage as much as possible. And for episode approaches, it should be national to align with inpatient prospective payments. Another area for improvement is beneficiary engagement. It's really important for providers to have the tools to engage beneficiaries. Have I taken 9 minutes already? Oh. Okay. It's really important for providers to have, I said that already. This starts with knowing who's attributed, and we really need prospective attribution of beneficiaries. I would like to see beneficiaries have an opportunity to identify their primary care physician, because that defines attribution to an ACO. And in some of the recent models announced by CMS yesterday, I think ACOs would have the ability to provide incentives to beneficiaries to use their primary care providers. I think a network approach would be much better, where the beneficiaries would choose to be identified with an ACO. There could be an incentive from the Medicare program or from the ACO to do this, and that there would be their cost sharing would be lower when they use in-network providers and higher if they use out-of-network providers. So this would allow the ACO to steer beneficiaries to their partner providers and others that they choose to designate as within their network. It would also provide a role in ACOs for physicians in many specialties, even if they're not partners who are sharing savings or losses. Now, this will need additional changes in how much Medigap can supplement Medicare. I think what MACRA did is a useful start, but there's going to have to be a provision so that differences in coinsurance in-network and out-of-network are not completely offset by the supplemental coverage. As far as quality measurement and alignment across providers, we do support the approach of using quality thresholds before shared savings are paid, but alignment in the measures is not there now. In the past, on many dimensions, such as the physician relative value scale, coverage decisions, private carriers and Medicaid programs have followed Medicare. This is not happening so far in ACOs, where they're all using their own quality measures. Presumably, they're not finding the Medicare measures attractive enough to follow, but I am optimistic that the various discussions that are happening between carriers, CMS, and provider leaders under the sponsorship of AHIP might actually move us in that direction. Ultimately, we're going to need quality measures that are meaningful to beneficiaries, including clinical dimensions as well as the patient experience. In particular, we're going to need summary measures, whether they're star ratings or something else. I think there are opportunities to expand the range of services covered, and it's particularly important to include post-acute care in as many approaches as possible. The Institute of Medicine's geographic panel showed how most of the variation in Medicare spending geographically was based on variation in post-acute care. So it's important to include this in as many bundles as possible. It's already in the ACOs. For bundles that have significant Part B drugs, certainly they should be included in the bundles, and I'm pleased to say that the CMS recently announced an Oncology Bundle that includes both Part B and Part D drugs. I think there's a need for additional bundles outside of inpatient settings, but I believe CMS will need to customize many of them. Here are some of the characteristics of promising bundles, and this comes from a Bipartisan Policy Center report published in January that I played a role in. High volume episodes, episodes with substantial variation in spending from provider to provider, relatively small number of providers to coordinate with each other, presence of clear objective clinical guidelines that trigger the episode, and also treatments that are not especially supply sensitive. So a few comments on the path forward. I do believe we need to mandate reform payment for specific services. This will allow it to apply to more beneficiaries, improve more beneficiaries' care, generate greater federal savings, and resolve those very challenging benchmark issues that I discussed above. I think we need to broaden the incentives for providers to participate in reform payments, and I can envision applying the approach in MACRA, which was focused on physicians, to other provider types. There needs to be some work on the resolution when multiple payment approaches apply to the same beneficiary. And CMS has appropriately made sure that savings are not shared twice, say by a bundled payment entity and by an ACO. But I'm concerned that the way in which they've done it could undermine ACOs. Basically, it all goes to the bundled payment entity, and we want ACOs to get a portion of bundled payment savings for steering the patient to an efficient provider. So in conclusion, I think realization of payment reform realizing the potential of payment reform will require improving the payment models. We really need to get wider provider participation. This will improve the outcomes of care and gain budget savings for more beneficiaries and allow the movement away from provider-specific historical benchmarks. And voluntary participation is just not a long-term strategy. So I can say, just imagine, what if we had pursued inpatient prospective payments as a voluntary program back in 1983? Can anyone imagine what it would be like today? The program probably would have crashed years ago. Thank you very much. I'd like to turn next to our discussant, Mark Mcclellan.
Thanks, Paul. And I want to thank Paul and Gail for a very thoughtful overview and lots of recommendations on the next steps in this dynamic and also complex area, but very timely area of payment reform. This matters. It's getting a lot of attention. Paul mentioned the Secretary's priority on it. It's a major activity in every private insurance plan and at the state level, too. And obviously what Medicare does makes a big difference in what happens for the overall healthcare system's adoption of payment reform. So in the paper, they review some of the key experience to date under Medicare payment reforms, including medical homes and bundled payments and ACOs. They note, however, that although these are promising, many of them are early in implementation, have been subject to limited formal review, and so I think the words you used were, any conclusions so far are tentative. The reforms as well have generally shown either no results or modest savings. But nonetheless, they urge continued steps to implement and refine these payment reforms, and indeed, as you just heard Paul highlighting, encouraging the aim of mandatory, not voluntary payment reforms. And they've got some specific suggestions for doing so. What I want to talk about first is that this raises the really good question of what are the right reforms and what should be the basis for proceeding on them to this level of stronger, mandated, potentially major changes in the way that healthcare payments work. And Paul talked about some of the things to look for in that respect. One approach might be observing what providers are saying, and in the absence of better evidence, relying on the take-up of reforms by providers and the persistence of providers in these payment reform programs is a very important consideration. Hospitals, physician groups, other healthcare organizations have been very actively engaged in Medicare's payment reform process and have expressed a number of frustrations with it. But there is a trade-off. For one thing, if you have too much early participation in payment reforms, it may turn out to be a mistake if that reform doesn't pan out in terms of improvements in outcomes and reductions in costs. And as they pointed out, there's some reasons for skepticism given some of these early models. For another, a way to get more participation is definitely to make the terms more favorable to providers, give them more money up front, reduce the financial exposure, risk of financial losses. But if you do those things, as the actuaries will tell you, it can be harder to make sure that the reforms really will drive transformations in care and reductions in costs. And a third point is that while I deeply appreciate the hard work of my former colleagues at CMS, what I think we've learned is that when you're undertaking some big major reforms, some substantial reforms in the way that payments work, it is very hard to get them completely right out of the gate. And for that reason, it might be a good idea to limit participation until experience and evidence is accumulated. And that kind of gradual rollout strategy is what many private payers are doing today with their payment reforms. So they're aiming high, but starting with a limited number of providers and then going up kind of gradually over time. So I wanted to take these ideas and kind of apply them to some of the very recent experience with Medicare's payment reforms, particularly in the Accountable Care Organization program, since great timing for this event, version 2.0 of the Medicare Shared Savings Program was just announced by CMS yesterday afternoon. This revision to the ACO program was based on a proposed rule released late last year and the experience of the program over the first couple of years that raises all of these points that we've just been discussing. Now, we're still going through this regulation here. It just came out, but the new revised framework acknowledges and begins to address a lot of the suggestions raised in the paper. These include a commitment to transition from provider-specific benchmarks, which is pretty much what you have to use at the start of a voluntary program, to a benchmark system that's based on something like regional costs and that recognizes the importance of rewarding high performers as well as improvement. It includes prospective attribution of beneficiaries and beneficiary attestation to the organizations that they're in for the ACOs that are moving farther down the road to major payment reform, including taking on so-called downside financial risk, the more substantial payment reforms that Paul and Gail have highlighted as being potentially desirable if they work. CMS understandably focuses the most substantial reforms in these areas where there is the biggest movement away from fee-for-service, and has also announced recently some further pilots in the next generation ACO program, like opportunities for beneficiaries to share in cost savings for using providers that are part of this payment reform program, opportunities for ACOs to share savings with specialists and other physicians who aren't formally members of the ACO but who treat the ACO patients. So there are some steps moving in this direction. I also wanted to highlight a couple of other things that CMS has listened to providers on. One is the very important issue of effective data sharing so that you can reduce the uncertainty about how you'll do in these programs. Also some issues related to risk adjustment and the like. So there is this kind of iterative process going on. Second, CMS made very clear in this regulation that they were trying hard to make the program revisions based on the evidence. So as you heard from Paul, the evidence so far in the Medicare ACO program could be regarded as modest. In the first year or two, I guess in the first 2 years of the Pioneer ACO program, counting the ACOs that subsequently dropped out, they got savings estimated on the order of $300 per beneficiaries. Maybe that's modest. A subset of these ACOs have done much better, and more of them have done much better than would be observed by chance, which again maybe makes you think that the program shouldn't be adopted by everyone, or that there's some ways of reducing uncertainty about how much how organizations can actually succeed in these bigger payment reforms. But in any case, this evidence of savings was regarded by the CMS actuaries as substantial enough to lead to an actuarial certification that expanding the Pioneer-like program would significantly reduce Medicare program costs. And in turn, this was the basis for incorporating, or at least part of the basis, for incorporating the significantly revised version of the Pioneer program as a full part of Medicare now, or at least when the final rule takes effect. So when provider acceptance is one important consideration for broad acceptance, that's absolutely right. So is generating the best possible evidence. And what we need is better ways to do both more efficiently and faster. And I think there's some good ideas for that. We've talked and written about the better, faster evaluation methods elsewhere. I would also highlight the important recommendation of alignment in payment reforms across providers. That's a very good idea. It's hard to see how healthcare providers can sustain big improvements in care if different providers or if different payers are pulling the healthcare organizations in lots of different directions. In the paper, the focus is on quality measure alignment. I just want to emphasize that it's important in other areas too. The types of payment reform models adopted, the attribution and benchmarking methods, the data sharing methods, lots of things beyond quality. And the main recommendation in the paper is that, I think, is that Medicare maybe shouldn't lead the way with private payers following, but there should be a collaborative process, even though, Paul, you highlighted Medicare leading the way in the past. And I think that it is true that in the past, private payers have typically have sometimes followed Medicare in these previous payment reforms. I'm not sure that's going to be the case here. For example, in moving towards real risk-sharing models like the Blue Cross of Massachusetts Alternative Quality Contract, the private payers are actually leading the way. They're doing kind of bigger, more substantial reforms than CMS has been able to do so far on a large scale. So I appreciate their highlighting a different approach, one that involves more public-private collaboration in getting from here to there in this complex process. And that is the main focus of the recently announced Healthcare Payment Learning and Action Network, to try to take up that challenge. And then just before I wrap up, a few words about bundled payment reforms, which were a big part of the focus in this paper. Once again, I'd urge trying to find a way to make sure that we're balancing participation and rapid adoption with more efficient and better evidence development. This has turned out to be a bit challenging for bundles that go beyond discrete elective procedures like bypass surgeries or joint replacements. I think one of the most popular bundles in Medicare's Bundled Payment for Care initiative, one that's mentioned in the paper, is congestive heart failure, which is an area where there's certainly room for improvement in care. But if you look at some of the best practices in this area, the best care is that kind that doesn't result in nearly as many admissions to the hospital for this condition, this chronic condition, in the first place. So just focusing on, as Medicare has done so far, on hospital-based procedures is only going to take you so far. And for chronic diseases like heart failure, that especially in the Medicare population, usually go along with other chronic diseases like diabetes, kidney disease, other conditions, it can be hard to separate out a specific bundle. And so maybe a more comprehensive medical home payment with accountability for overall costs and outcomes might be better. That's what a number of private insurers are doing now. In fact, the fastest growing group of ACOs in the country, both in Medicare and in the private sector, are those that consist mainly or entirely of primary care physicians supported by care teams who are starting to take on overall cost and outcome accountability for patients like these and working selectively with specialists and hospitals when needed. So a lot of good stuff here. I did want to come back to the authors with one question, since we're talking about Medicare 2030, which is, what do you think payments should look like 15 years from now? I know the complexity of this area and the need for better evidence on what really works makes that hard to address. We took a stab at this in a report that we did last year in 2013 on bending the curve in healthcare, that it featured ACOs with payments that are much farther in the direction than we have today towards partial capitation, with benchmarks tied to overall growth in the economy, coupled with payment models that work well for smaller, less integrated groups like primary care groups or oncology groups taking on significant risk for, at the patient level and collaborating with other specialists through payment reforms that help them fit together. But this is an area that I think is unsettled, and the more that we are able to develop a clear vision about where we're headed, I think will help with focusing the implementation of effective, well-coordinated pilot programs that can hopefully turn into real impacts on care. Thank you all very much.
I wasn't quite sure what the role of co-author was in this kind of a panel, so I'm going to just try to emphasize 3 or 4 points that Paul made in summarizing our paper and that Mark has alluded to as to what I think the issues are most important as we've identified. The first is to recognize how much change is going on right now. We have to be careful, as Mark said, that we not get so much change that we aren't able to document what is driving the observed changes, and also because we want to be careful not to overload the system, either in terms of the administration implementation part or in terms of not being able to understand the kinds of effects that are resulting. We thought this question that we pose about should we think about ACOs and some of the other pilots as necessarily on the road to Medicare Advantage is one that needs to get more attention than is sometimes given. There are some opportunities that are very difficult to achieve if you do not have a fully at-risk plan. And we can talk about some of the differences that go on if you have a full risk ACO versus a Medicare Advantage, other than the fact of the insurance function per se and how much effect that has, and other than whether or not you have patient engagement, which is now not so obvious or easy in a full risk ACO, but might become different over time. And at that point, is there actually very much difference between those two models, and does it matter? So that'll be a question. When you were describing your thoughts about where we might be in 2013, parsing out how that differs from well-functioning Medicare Advantage plans becomes interesting. Not that there aren't any differences, but there might be much smaller differences than we traditionally have thought about when we have these two models. The other real question that we have raised had to do with, Paul mentioned, this voluntary nature and the trade-off between jumping too fast to enforcing a particular innovation and realizing that some changes are so much more difficult to implement if they're on a voluntary nature, the benchmarking being one that we reference in the paper. Although we did see what is in the MACRA legislation as an interesting alternative to not requiring mandatory adoption of a particular innovation, which is to say that providers could have a choice of being in one of a limited specified number of alternative delivery systems that presumably have been shown to improve value, or to meet a set of metrics that would reflect both clinical outcome improvements and better value for the beneficiary while still in a fee-for-service world, or face a much less pleasant financial environment that is either no updates or, in fact, even negative updates, that is getting dinged for those kinds of metrics. And that is somewhat different than what we have traditionally done in Medicare, and that's really one of the most challenging questions. The other is, and we hear this all the time in healthcare, the devil's in the details. Well, this really becomes an issue here because you need to specify which of the metrics are going to determine whether or not somebody that is providing services to Medicare in traditional fee-for-service should qualify them for receiving a bonus. We wanted to press the point, let's not forget those that are important to the beneficiary in addition to more traditional clinical outcome and or process kind of measures, but also which of these alternative delivery systems ought to automatically qualify you for a bonus, because we've been impressed that what we've seen to date, while in concept promising, in practice has been, I'll use the modest, shall we say, but pretty darn modest indeed, and especially when done by independent evaluation. The good news is that what might have been the response of CMS or the provider community is throw all of this out and start over again in your thinking, seems to be instead generally good ideas. We haven't figured out how to make them function better, and that's really where we are now. And so on that ground, I think there really is some promise. Learning that pilots are tough and trying to figure out which works and which don't and move on, getting evaluations, and not doing it so quickly that we get lost in the middle, but not letting it drag on so long that we actually do imagine a world post-1983 where DRGs are still voluntary. Let me stop there.
Good.
Just a couple of questions.
That's right. Just one thought responding to things that Mark and Gail said about 2013. I think in
2030?
2030, that's right. I think in Medicare, I think that non-fee-for-service payment will be very important in 2030. What is hard to see now is whether it's predominantly ACOs or predominantly a combination of bundled payments and an advanced medical home idea where the primary care physicians are at some risk for global spending by beneficiaries attributed to them. The other point I want to make is that it's likely that we're going to see a lot of parallelism between what Medicare Advantage plans do to pay providers in their plans and what traditional Medicare. You know, when we talk about alignments of methods used by insurers, some of those insurers are Medicare Advantage insurers. So we can think down the road about what will be the strengths of Medicare Advantage plans versus traditional Medicare if they're both heavily using these approaches to pay their providers. Like to have some questions? Yes, there's someone over there.
Bill Martyr from Truven Health. This is maybe the guy with a hammer looking for nails, but we're living in a world of diverse reimbursement regimes for years going on into the future. It would be nice to have a consistent measure of what's happening across those reimbursement regimes, and encounter data could do that. A face-to-face encounter between a provider and a patient is going to happen in all of those reimbursement regimes. And we've had Part C for a long time with very limited encounter data. So the question for two former administrators, why don't we get more detailed information from our managed care plans so that we can actually look at what happens inside the black box?
Well, the practical reason is a very simple one, which is that to date, they don't have to report on an encounter basis in order to get paid, unlike fee-for-service, where if you don't have reportable, documentable encounters, you won't get paid, and if you do get paid, you'll get challenged. So it would have to be a specific requirement that you provide encounter data. That is unlikely to be viewed as in a friendly way unless there is a payment for that kind of reporting the way we did for quality, hospital quality metrics. But I think you need to be careful about what would be reasonable to ask for and whether we want to focus. I mean, encounter data sounds an awful lot like focusing on inputs when we keep trying to move to a focus on outcomes and appropriate clinical measures. And we would have to be very careful that this does not end up in a requirement of doing things in a fee-for-service mindset that is basically the opposite of what you want to encourage in a Medicare Advantage program, where if you're doing it well, you could have good integrated care, coordinated care for treating chronic diseases. So you are correct that the ability to understand what is going on during visits is becoming increasingly challenging as more and more people are in Medicare Advantage, and traditionally there has just not been very good data on that basis. We need to make sure what we ask for is not framed within the fee-for-service mindset.
I agree with my fellow former administrator, more former administrator, maybe, but where the emphasis seems to be going, including in that collaborative plan, Medicare, hopefully broader process soon on performance reporting, is towards more clinical measures, more outcome-oriented measures, which in principle could be based on encounter data, but are much more things like hemoglobin A1C levels, patient-reported functional outcomes. I think in some cases, use of evidence-based approaches to clinical care. That's where the main thrust seems to be, because exactly what you said, it's tied to what these payment reform, more directly tied to what these payment reforms are intended to support, not something that's more about utilization. Consistency.
Well, what you want to ask is why don't we push the fee-for-service world to be much more focused on outcomes the way we have in terms of what we now call Medicare Advantage. I mean, we're going to get the input measures as long as we pay on an input basis. What we haven't done, especially in ambulatory care, and what I think is a completely shameful way for traditional Medicare, is insist on the same kind of outcome measures, crude and elementary as they sometimes are, in the traditional model that we have in the at-risk model, and that's been true basically for the last 2 decades.
Yes. Question there?
Lee Rucker, independent policy consultant. My firm is called Enhanced Value. Having read these papers in reverse order, I was fortunate to start with this one. I was very energized. I particularly appreciate the references on the patient engagement and also quality. My question goes to perhaps the opportunities in these alternative payment models for potentially multi-year budgeting, if you will, or multi-year incentivizing of patients. Might there be opportunities that if a beneficiary agreed to stick to a particular ACO, if you will, for maybe a three-year period or something, would there be particular shared savings or some sort of reduced payments? I'm thinking particularly in much of my work has been in the pharmaceutical policy arena. Greg Daniel referenced earlier with the new Hep C drugs, the frustration on insurers that if they pay for the drug up front, the long-term benefits accrue to the patient by the time that they have moved on to another plan. In Australia, pharmacists have 5-year agreements with the government to be compensated for pharmaceutical care services beyond just the dispensing. So I just wondered if there might be considerations along that line. Thank you.
Well, I would think that it's actually, we have so far to go just to establish beneficiaries designating that a primary care physician is theirs or an ACO, that in a sense, I think it would be much harder to get the political system to move that way if it were for a multi-year period. So maybe in 2030 might be a time to go there.
Come back and ask the question, 2030.
Thank you.
You can get, as you mentioned, there are, many of these contracts, they have payment reforms. They have elements that go beyond 1 year. You mentioned Australia having the 5-year. I mean, that's what the provider in the Medicare ACO first round program, that was a 3-year contract. This new revision envisions kind of a longer term pathway than that, potentially. Utah has recently implemented some accountable care ACOs through managed care organization reforms, where they made a commitment not to rebase the budget off savings for years to come. We'll see if the state can stick with that, but it does help provide for a longer term focus on what's really going to get outcomes improved and costs down, and those strong relationships with patients can be a critical part of that. So even though you may not get to like a 3 or what would be perceived as a 3 or 5 year patient lock-in, I think some of these kinds of programs and payment reforms and reforms on the benefit side could help support that.
There's no question you could look to invoke strategies that have medium-term payoffs, not necessarily really long-term payoffs, if you could get an agreement for other than a year or even a year or two. But we're going to have to wait on that. It's very hard. We are still grappling to figure out which of these kinds of payment reforms seems like it really has legs and will go successfully into the future. But it is an important issue.
Let me hand off to Dana Goldman.
Great. Thank you to the panel. And thank you, everyone. If Bob Reischauer is correct that it's 10% about the policy and 90% about implementation, we got the 10% here, so we'll let you continue. Thank you very much.
Thank you. Thanks, Mark. Good ideas.